So, hello everyone. So, now we will start with the session. So, starting with the Clinical Anatomy MCQ series second. So, this is the second series which we are going to start. So, myself Dr. Monalisa. So, I think I am audible. So, okay. So, let us start with the session now. So, I have got a total of 8 years of teaching experience for various competitive exams in the medical field. So, before starting the session, I would like to tell you about the benefits of joining the Unacademy and about the platform of Unacademy. So, if you are going to take 3 months of subscription, you are getting additional 1 month of subscription absolutely free, and this is the code ANAT10 which can be used by you if you want to take the subscription of Unacademy. Boost your preparation by taking 12 months of subscription and get 2 months of subscription additional absolutely free. Savita Kulkarni, good afternoon dear, good afternoon. So, today we are also discussing the MCQ series which is clinical aspect. Before that, let me just give a brief introduction about the platform. So, limited offer for the iconic subscription of Unacademy where the merging of Prep Ladder and the Unacademy has been done. So, these are the discounted rate, whichever suits you, you can take the subscription. So, how to take the subscription? Download the Unacademy app, use the referral code ANAT10 for 10% discount, and then choose how many months subscription is needed for your preparation, whether it is for few months, years, 2 years, 3 years, whichever suits you. Referral code ANAT10 can be used by you for taking the plus subscription. You can be the part of live sessions, you can be the part of weekly test series, you can be the part of structured course, and unlimited SS is there. So, I would also like to tell you the new sessions which I am going to start from tomorrow. One of the session is must know topics for NEET PG 2021. So, I am starting an ultra rapid revision of the whole of anatomy in our 10 hours of course starting from 19th, and it is ending on 21st. Okay. So, 2 sessions on 19th and 2 sessions on 20th June, and it will end by 21st June, and the referral code that can be used by you is ANAT10 because this is on the plus platform. NEET PG season batches are going on. So, if you want to take the subscription, you can be the part of the session. Target Next 2022 batch. First year MBBS batch has been started on the Unacademy platform along with the batch third year batches and the second year batches. So, all these batches, whichever suits you, you can be the part of the session and you can take the subscription by using the code ANAT10. So, and also I want you to tell that those who want to see the free sessions on the Unacademy platform, they can just use the code ANAT10 to unlock free sessions on the Unacademy platform, and the free sessions which is going on the platform are, so I am taking 3 sessions now which I have updated about the conceptual anatomy topics. So, one is the lung which will be very useful for you. Today I am taking in the evening 6 p.m. So, if you are interested, you can join me. Tomorrow also 6 p.m. session is the part second of the lung, and on 21st June, that is Sunday. So, it's Sunday. So, I have chosen the morning hours. So, that is afternoon hours basically. So, I am taking the session at 12:30 p.m. So, this is the timing for today, tomorrow and day after tomorrow session of conceptual anatomy. Now, those students who are interested for solving the previous year MCQ, so that also series I have started. So, you can be the part of this series. 7:30 and 8:30 is the timing. So, tomorrow is 19th June and I am taking in successive manner 2 sessions, 7:30 and then 8:30. The session is of 40 minutes and 40 minutes, and we will discuss important MCQs of previous year targeting NEET PG 2021. So, yes, all the best. Now, let us start with the session. So, today let us start with the first. So, today also I have targeted 10 clinical MCQs and we will solve these all 10 clinical MCQs. All the best to everyone. Okay, so question number 1, I am reading it for you. You should mark your correct answer. A 34-year-old female has difficulty in abducting her right arm past horizontal position, and abnormal prominence of right inferior scapular angle is also observed in the patient. So, which of the following is the most likely the cause of the patient condition, whether it is thyroidectomy, anterior dislocation of shoulder joint, violent stretch between the head and the shoulder, clavicular fracture and mastectomy. So, whichever feels is the correct answer according to you, please give the answer in the chat box, and then I will come up with the explanation of the MCQ. 5 options are there and you have to mark the correct answer. Yes, Savita, you can also attempt. Take your time, take your time. Difficulty in abducting her right arm above the level of horizontal position. The key points: abnormal prominence of right inferior scapular angle is observed. So, according to you, what is the most likely the cause for the patient condition? So, 5 options are there and please mark the correct answer. Okay. So, yeah. So, actually the correct answer is, yeah, I got Dipti E ma'am. Okay. So, Dipti is telling E and Savita has not given. Okay. So, yes, E till now I got E as an option. Anyone else wants to give the answer? So, few students are listening. Okay. So, let me just give the answer and explanation. So, Dipti, Savita Kulkarni is telling C, Dipti is telling E. Okay. Actually, the correct answer is E. The correct answer is E, mastectomy. Okay, let me explain this MCQ. Actually, the key points which you have to mark in this MCQ is what is the difficulty which is observed in the patient. So, the 34-year-old female has got difficulty in abducting her right arm above the level of horizontal level and abnormal prominence of right inferior scapular angle. So, in this question the key points has been marked here. So, actually all these key points are targeting to the injury or paralysis of which muscle? Serratus anterior muscle, and the injury is to long thoracic nerve. So, the classical signs of serratus anterior muscle being paralyzed is if you ask the patient to push against the wall. If you ask the patient to push against the wall, he or she is not able to do so. And in doing that procedure, what will happen? The scapular medial border will appear as out, it will be protruded more outwards like a wing. So, the condition is called as winging of scapula. The second important point which is observed in the patient is unable to abduct the arm above the level of horizontal level. That means not able to move the arm above 90 degrees. Okay. So, yes, Sujita, absolutely right. So, long thoracic nerve is injured by penetrating wound, and generally what happens in cases of breast cancer, if the lymph nodes are employed, we want to remove the lymph node, we go for dissecting it and going for radical mastectomy so that all the structure which is involved is removed out. So, we are going to injure which nerve? Long thoracic nerve, and if long thoracic nerve is injured, there is paralysis of serratus anterior muscle, and we know that above 90 degree of abduction is done by which muscle? Serratus anterior muscle. So, this is the reason that the correct answer will be the injury to serratus anterior muscle, and the procedure which is involved is radical mastectomy. So, E answer is absolutely right. Now, moving to the second. So, my dear friends, I have already told you how to approach to the correct answer, but in clinical MCQs what my target is that we should also have a discussion on incorrect options. Okay, why? Because it will be more elaborate and we can understand how to rule out the incorrect option. So, one of the option was thyroidectomy. So, thyroidectomy can't be the answer. The reason is that actually in cases of thyroidectomy procedure, generally it's a midline structure of the neck. So, midline structures are involved, and injury is to the injury which is seen in the patient is generally when the procedure is done, we go for ligation of external superior larynx. What happens? We go for ligating the superior thyroid artery or inferior thyroid artery. Two arteries is ligated, one is superior and the other is inferior thyroid artery. Inferior thyroid artery and superior thyroid artery. So, in this procedure there is chance of the nerves being involved and the nerves being injured. The nerves being injured is recurrent laryngeal nerve and external laryngeal nerve. So, these kind of sign and symptom was not presented in the patient, and any of the structure lying in the midline of the neck region was not involved. So, this can't be the correct answer. Now, moving to anterior dislocation of shoulder joint. Anterior dislocation of shoulder joint again can't be the correct answer, because when there is anterior dislocation of shoulder joint, neck of humerus is involved and it will lead to the injury of axillary nerve. कौन सा nerve injured हो जाएगा? Axillary nerve. And we know that Axillary nerve is supplying which two muscle? Deltoid and teres minor muscle. And if deltoid is involved, so the loss of abduction is there, but loss of abduction will be occurring from 15 to 90 degree. In the patient, loss of abduction was above 90 degree, above horizontal level. So the major acromial fibers of deltoid is causing abduction of arm or shoulder joint ranging from 15 to 90 degrees. So this can't be the correct answer. Now, violent stretch between head and the shoulders. Violent stretch between head and the shoulder. Actually, when there is a violent stretch between head and shoulder, that is the most common injury, is the mechanism of injury is delivery during trauma in adults. So it will lead to the injury to upper trunk of brachial plexus. And when upper trunk of brachial plexus is involved, what will happen? It will lead to classical Erbs-Duchenne paralysis. So clinical feature in this kind of patient will be, the patient will have policeman tip abnormalities and the arms will be adducted and medially rotated. Arms का position कैसा होगा? It is medially rotated and adducted, and forearm is extended and pronated. The forearm is extended and pronated. This presentation of the patient is called as policeman or the waiter tip deformity. So this can't be the correct answer. So let's move on to the last option before approaching to the second MCQ. So the other option which was wrong was clavicular fracture. Clavicular fracture again can't be the correct answer, because generally when clavicular fracture occurs, it is not leading to any kind of nerve palsy. Okay, typically the involvement is in the middle part of the clavicle, and there can be any injury to the ligaments attached to clavicle, but generally what is seen in the cases, whenever the clavicle fracture is involved, the nerves are not involved. So this is the reason this can't be the correct answer. So yes everyone, can we move to second MCQ? So let's move on to the second MCQ. Sanjay Kumar, clinical features. Okay, clinical feature of which one? What you are asking? What you are asking? Clinical feature of clavicle fracture. When clavicle is fractured, okay, when clavicle is fractured, medial end of the clavicle is moved upward. Medial end of the clavicle is moved, so whenever the clavicle bone is fractured, so for example, if the clavicle bone is fractured, so its medial end of the clavicle will be moved upward. And what is the reason of the medial end of clavicle being moved upward? The reason of medial end of clavicle being moved upward is by the pull of sternocleidomastoid muscle. Okay, sternocleidomastoid muscle. So is it okay, Patil, Sanjay? The medial end of the clavicle is moved upward by the strength of sternocleidomastoid muscle, because the clavicular end of the sternocleidomastoid muscle is attached onto the medial aspect of the clavicle. So one of its part, when you will go for X-rays, what you will see, the medial aspect of clavicle is moving upward. So done. Let's move on to the next MCQ, MCQ number 2. Now let's move on to the second MCQ, all of you. So I will read the MCQ for you and you have to mark the correct answer. A young athlete presents to your office after sustaining an injury to the right upper extremity. Okay, physical examination reveals weak right forearm flexion and absence of biceps reflex. Good afternoon, Shruti, good afternoon. So given these findings, sensation loss of which of the following area is found? So we have got 5 options. Please mark the correct answer, whether it is posterior arm, posterior forearm, lateral forearm, medial forearm or thenar eminences. 5 options are there, my dear friends. So just mark the correct answer. So your time starts now. I will give you 30 seconds and then I will mark the correct answer. So today also be connected, because altogether we have got 10 clinical MCQs, and in that 10 clinical MCQs I am going to explain not only the correct option but also the incorrect option. So it will be very beneficial for you. So yes, I got Sam is telling it's D, medial forearm. What about others? What about others? So Sam is telling it's D. Shruti Kumar is telling it's D. It's D. Okay. Okay, so let me just find out what is the correct answer. So let's everyone mark the answer so that I can explain. So Sam is telling C. Sam is now telling C. Dipti is telling D, okay, Dipti is telling D, so C and D. Most of you are telling either C or D. So Veena Carla is also telling D. Veena Carla is also telling D. What about others? Okay, so let me come up with the explanation. Okay, I have got Subham Chandel is telling E. Okay, Chandel is telling E, thenar eminences. Actually, can I come up with the right answer? Actually, the right answer is C, lateral forearm. Lateral forearm. So Sam is right. Firstly, he has given D, but now he is telling C. So absolutely right, Sam. Yes, those that C option is absolutely right. Now, the key points which help us to approach to the right answer is injury is on the right upper extremity and the weak right forearm flexion. So, flexion is gone and loss of biceps reflex. So, these are the key points: loss of biceps reflex and also weak forearm flexion, weak forearm flexion. So, these are the key points which is mentioned in this MCQ which will help us to approach to the right answer. The right answer is C. Okay. So, let me come up with the explanation. The patient has, yes Sam, musculocutaneous nerve, absolutely right. Yes, the patient has symptoms suggestive of musculocutaneous injury, absolutely right Sam. It innervates the upper arm flexor muscle and on the anterior aspect of arm, in the anterior aspect of the arm, the flexor muscles are biceps brachii, brachialis and coracobrachialis. What three muscles are lying on the anterior aspect of arm? Biceps brachii, coracobrachialis and brachialis. So, after innervating these muscles, the remaining fibers continues becoming lateral cutaneous nerve of forearm, which is providing sensory sensation to the skin of forearm, lateral forearm. So, these are the key points. The key points which was mentioned in the MCQ was loss of biceps reflex, means biceps brachii is involved in biceps reflex, and so the musculocutaneous nerve, we are very easily knowing that musculocutaneous nerve is the right answer. The next point, how to approach to the right answer is, we have to know the course of musculocutaneous nerve. Musculocutaneous nerve terminates by becoming lateral cutaneous nerve of forearm. So, that is the correct answer. Now, I would like to give you the key points. How you are going to mark the correct answer. Lesions of musculocutaneous nerve in the elbow. So, if there is lesion in the musculocutaneous nerve in the region of elbow, the characteristic mechanism of injury is generally a penetrating injury to the axilla, stab injury, iatrogenic injury, means any kind of severe injury, and if it is involving any kind of severe injury to the during the deltopectoral approach of shoulder, as a heavy retraction is done. So, the motor function of three muscle, musculocutaneous nerve, we know that the musculocutaneous nerve is a branch of lateral cord of brachial plexus and it gives branches to biceps brachii, coracobrachialis and brachialis muscle. So, after supplying these three muscles, after giving innervation to these three muscles, musculocutaneous nerve becomes lateral cutaneous nerve of forearm. Means the action of these three muscles along with the sensation on lateral aspect of the forearm is gone. So, let me show you more explanation. Actually, if these three muscles is not functioning, brachialis, biceps brachii, the flexion of shoulder joint and elbow joint is both weakened. My dear, I am using the word weakened but not complete absence. Why? Because still the pectoralis major and brachioradialis muscle is working. Okay. Why? It is only weakened. Complete loss of flexion of shoulder or elbow is not possible. Why? Because still pectoralis major muscle is intact and pectoralis major muscle is causing flexion of arm. Same way, brachioradialis muscle is getting innervation from radial nerve. Pectoralis major is getting innervation from pectoral nerve, lateral and medial pectoral nerve, lateral pectoral nerve and that of medial pectoral nerve. Brachioradialis is getting innervation from radial nerve. So, still these two nerves are intact and these two muscles are intact. So, complete loss of flexion is not possible, and brachioradialis is also causing slight is supinator muscle. So, that will also become weak, but complete loss is not possible. The other points which help us to approach to the right answer is, Loss of biceps tendon reflex. This was the key point which was mentioned in the MCQ, and loss of biceps tendon reflex is also seen in case of musculocutaneous nerve injury. Sensory loss will be seen in the lateral aspect of forearm. Can you see the blue color area which is highlighted is actually showing the cutaneous area of cutaneous innervation. It is showing the area of cutaneous innervation by musculocutaneous nerve, and also there is loss of biceps reflex. Now, so this all points which I have mentioned is helping us to approach to the right answer. Now, I want to tell you about the explanation for the other option. Why posterior arm is not the correct answer? Posterior arm is not the correct answer because posterior arm cutaneous sensation is done by which nerve? Radial nerve. And radial nerve is not injured in the patient. So, it can't be the correct answer. So, this option is absolutely wrong. So, why posterior forearm is not the correct answer? Because cutaneous innervation of posterior forearm is again done by a branch of radial nerve, that is posterior cutaneous nerve of forearm, and radial nerve is not involved in this case. So, it can't be the correct answer. Coming to the other option, one of the option was medial forearm. My dear friends, if you know the branches of ulnar nerve, you must be knowing medial cutaneous nerve of arm and medial cutaneous nerve of forearm are the branches of ulnar nerve, and in this case ulnar nerve is not injured, so this can't be the correct option. Thenar eminences. So, thenar eminences containing three muscles. So, this is the area of thenar eminences below the thumb. This area is the thenar eminences. It is consist of muscles like abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and these muscles are getting innervation from median nerve, and median nerve is not injured in this patient. So, this can't be the correct answer. This can't be the correct answer. Is it okay everyone? Can we move on to the third MCQ? Can we move on to third MCQ? Ready? So, let's move on to the third MCQ. Question number third. So, yes. Just read the option and mark the correct answers. So, I will read it for you. A 24-year-old mountain climber present to the emergency room with right shoulder pain following a fall. He was climbing a cliff at a nearby national park when he lost his grip and fell approximately 5 meters onto the boulders below. He says he landed on his right arm and heard a bone snap. Physical examination reveals total inability to extend the right wrist. Total inability to extend the right wrist. This is the hint to the correct answer. X-ray reveals a fracture of right humeral shaft. So, this is the second hint to the correct answer. Key points to mark the correct answer. Now, tell me which of the following artery is injured in the patient. Options are anterior circumflex humeral artery, brachial artery, common intrusious artery, deep brachial artery, or radial collateral artery. Yes, Dipti. Yes, so I am getting Prakhar Sharma has given the answer D. What about Sam? What about Dipti? Sam is telling it's D. So, let others mark the correct answer and then I will explain this MCQ. Sam is telling D, Prakhar Sharma is telling D. Yes, Dipti, what's your answer, Dipti? Dipti, Veena Carla, Shruti. Okay. So, yes, few students has given the answer as D. The key points are already mentioned. Extend the right wrist, inability to extend the right wrist, and the location of injury is humeral shaft. Humeral shaft, the location of injury is at the level of humeral shaft. So, actually the correct answer for this patient is, and this mountain climber is, the injury is to deep brachial artery, profunda brachii artery, that is deep brachial artery. What is the other name of profunda brachii artery? So, D option is absolutely correct, and Dipti has told B. So, slightly confused Dipti. Okay, no worries. Actually the correct answer is D. Okay, Sam and Prakhar, you are right, absolutely. I will explain it. Don't worry, Dipti, I will explain it. Okay, now let's read slight anatomy to understand this MCQ. So actually the key points which was mentioned in this MCQ was location of the injury. So what is the location of injury? Mid shaft. कहाँ पे location है injury का? Mid shaft. Injury location is in the mid shaft. So mid shaft is involved, that is the location. And the other point is, so if we are knowing the mid shaft is injured, that means the structure is involved in spiral groove or radial groove, and two structures are related in the spiral groove. One is the radial nerve, another is deep branch of brachial artery. Okay, Dipti. So actually the key points which is mentioned in this MCQ is the location of the injury. Location of the injury is in the area of mid shaft of humerus, means humerus का shaft involved है. So जब हम humerus के shaft mid region में involved है, that is the region of radial groove or spiral groove, and we know that two structures are lying there in the spiral groove or radial groove. Two structures are lying there, one is artery and the other is nerve. The nerve is radial nerve and the artery is profunda brachii artery. And profunda brachii artery other name is, if we talk about profunda brachii artery, its other name is deep brachial artery and radial nerve. Also in the, if you go through the MCQ once again, and if you remember, there was a loss of extension was lost. So that was the key points to get you to identify the radial nerve. So here also in this diagram, if I will slightly enlarge, let me just slightly enlarge it. So can you see, this is the region of radial groove, and the structure which is lying in the radial groove, as you can see here, is the radial nerve and the deep artery of the arm, that is the profunda brachii artery. So is it okay, Dipti? Can you appreciate here? I have just enlarged that diagram. So this is the area of radial groove. This area is of radial groove, and the structure which is lying is the radial nerve and the deep artery of the arm. Okay, so let's move to the other option. So this was enough for the correct answer. So can we move on to the incorrect option? Let's move on to the incorrect option now. Anterior circumflex humeral artery, it is not correct, and the reason why it is not correct is the anterior circumflex humeral artery is a branch of, it's a branch of, can anybody tell me anterior circumflex humeral artery is a branch of? Anterior circumflex humeral artery is a branch of, can anybody tell me the answer? So we have got two humeral arteries, one is anterior and another is posterior and anterior. These are the branch of third part of axillary artery. These are the branch of third part of axillary artery, and these structures lies on the surgical neck of the humerus. Now surgical neck of humerus was not involved in this MCQ. If we will see the explanation and if we will see the MCQ once again, we can clearly see that surgical neck of humerus was not involved. So the branches of third part of axillary artery, that is the anterior and posterior circumflex humeral artery, is injured only when the surgical neck of humerus is involved. And when the surgical neck of humerus is involved, the nerve which is involved is axillary nerve. So right, so in that case axillary nerve is involved. Yes, Harini, absolutely right. Got it? Now why can't the correct answer will be brachial artery? Brachial artery क्यों नहीं correct answer हो सकता है? The reason is that brachial artery is coursing. If we see the course of brachial artery, it is moving anteromedially in the arm, and the location is in the bicipital groove. It lies in within the bicipital groove, and brachial artery is overlapped by bicipital aponeurosis. Okay, so exact location of brachial artery is in the cubital region. It is covered by bicipital aponeurosis, and at the level of the radius neck, it divides into two terminal branches, that is radial and ulnar artery. And the common injury level, which is the common site of injury of brachial artery and being involved, is supracondylar fracture. What do you mean by supracondylar fracture? Means the injury level will be above the condyles of humerus. The injury level is above the condyles of humerus. So supracondylar fracture lesion was not involved in the patient. Location was exactly mentioned. So this can't be the correct answer. Now common introosseous artery. One of the option was common introosseous artery. This common introosseous artery cannot be the correct answer. We know that common introosseous artery is a branch of, it's a branch of ulnar artery. and ulnar artery is one of the terminal branch of brachial artery. So, common intrusious artery is a short branch of ulnar artery, and again the common intrusious artery give rise to anterior, posterior and recurrent arteries branches, and actually the ulnar artery itself is given at the level of neck of radius, and so it is quite lower to that level. Termination, actually ulnar artery is one of the terminal branch. We have got two terminal branches of brachial artery. Brachial artery is giving two terminal branches, one is the ulnar artery and the other is radial artery. So, it is given at the level of neck of radius below the elbow region, elbow joint. So, this can't be involved in the region of mid shaft of humerus. So, this can't be the correct answer. Radial collateral artery, again radial collateral artery can't be the correct answer. The reason is that radial collateral artery is originating at the lower end of spiral groove. So, this radial collateral artery is also can't be the correct answer. Actually, this artery is given at the lower level. It is a branch from the profunda brachii artery, and it is given at the lower level. It is given at the lower aspect of the spiral groove, not exactly related close to the radial nerve. So, this can't be the correct answer. If it has, because in the MCQ it is directly mentioned the radial nerve being involved and the artery which is lying close to it is involved. So, in that case profunda brachii artery is the correct answer and radial collateral artery is not the correct answer. So, is it okay? Can we move on to fourth number MCQ everyone? Is it okay everyone? Let us move on to fourth number MCQ. Okay? Yeah. So, let us move on to question number 4. Okay, a 34-year-old swimmer presents to your office with external ear infection. While inspecting the patient, you insert a speculum into external auditory meatus lying very close to the posterior wall. When you are seeing the external aspect of the ear, you introduce the speculum very close to the posterior wall. The patient faints during the procedure. Irritation of which of the nerve was most likely induced by this procedure, whether it is vestibulocochlear nerve, vagal, trigeminal, facial or accessory nerve. So, mark the correct answer. We have got 5 options, just mark the correct answer, which would be the right answer. Five options are there, question number 4. Vestibulocochlear, vagal, trigeminal, facial or accessory. So, yes, Prakhar Sharma is telling it's B. Prakhar Sharma is telling it's B. What about others? So, yeah. So, only Prakhar has given the answer. Rest of you please try. Sam is telling it's D, facial nerve. Okay. So, I got Dipti is telling it's B. Dipti is telling B, Sam is telling D. Okay, let us see the others. Answer, 34-year-old swimmer. Okay. So, let me explain the answer, question number 4. Okay. So, here the key points which you have to keep in mind is that examination of external auditory meatus is done. External auditory meatus is being examined. The second point which is very important is that the speculum is introduced very close to which structure? The speculum is introduced very close to the posterior wall. It is involving the posterior wall is examined here. So these are the key points, and that means we have to know the innervation of the external auditory meatus wall wise. We have to know exactly the detailed information or anatomy of innervation of external auditory meatus. Actually, the correct answer here is vagal nerve. So yes, Prakhar and Dipti both are right. B is the correct answer. Vagal nerve is the correct answer. Let me explain this. So the patient described in this MCQ has experienced, so the patient faints, this was mentioned in the MCQ. So the patient is experiencing vasovagal attack. Okay, vasovagal attack. So again, Praveen Sinha and Akshay is telling E. Actually, the correct answer is B, that is vagal. So please everyone just see the explanation, those who have done the mistake. So vasovagal syncope, the patient is experiencing a fainting attack, that is vasovagal syncope, after the stimulation of posterior wall of the external auditory meatus by introducing otoscope. Okay, speculum is introduced and the examination is done of the external auditory meatus, and this will lead to vasovagal syncope. So in this form of syncope, parasympathetic outflow via vagus nerve leads to decreased heart rate and blood pressure. Okay, what happens when this procedure is done? The syncopal attack is due to involvement of vagus nerve, which leads to decreased heart rate and blood pressure. Now, posterior wall of external auditory canal. So this is the right approach to get to the correct answer. We have to know what is the nerve supply of posterior wall of external auditory canal, and the answer is the nerve supply of posterior wall of the auditory canal is by auricular branch of vagus. Okay, most of the remainder part, means the remaining part of external auditory canal, including the external aspect of tympanic membrane. If we talk about the rest part except the posterior wall, it is innervated by mandibular division of trigeminal nerve. And which branch of the mandibular division of trigeminal nerve? Auriculotemporal branch. Which branch? Auriculotemporal branch. The inner aspect of tympanic membrane, if we talk about the inner aspect of tympanic membrane, it is getting innervation from glossopharyngeal, that is the 9th cranial nerve via its tympanic branch. So if we just sum total of all these, we take these points in the mind. So what we can appreciate, the whole of external auditory canal is getting innervation by mandibular division of trigeminal nerve. Its posterior wall is getting innervation by vagus nerve, and the inner aspect, which is lying of the eardrum, where the external auditory meatus is ending, its medial aspect or inner aspect is getting innervation from tympanic branch of glossopharyngeal nerve. So this is the reason the correct answer will be vagus nerve. So you got everyone, is it okay? You got the right answer. That means posterior wall is involved. So 10th cranial nerve or the vagus nerve injury is the correct answer. Now moving to the incorrect option. So why vestibulocochlear nerve is not the correct answer? Why? Vestibulocochlear nerve, that is the 8th cranial nerve, is not the correct answer, because if this nerve is involved, we know that vestibulocochlear nerve is having two components, cochlear and the vestibular. Vestibular portion of the vestibulocochlear nerve is involved with balancing function, and cochlear portion is involved for the hearing. So these kind of loss was not mentioned, nothing mentioned in this MCQ. The history of the patient which was mentioned in this MCQ was not involving any kind of the loss of balance or loss of hearing. So this can't be the correct answer. Now moving to the next, trigeminal nerve. Yes, of course, trigeminal nerve could have been the correct answer, but why it is not the correct answer in this MCQ again? Because external auditory meatus, if we talk about external auditory meatus, all of its parts, major part of it is getting innervation from the mandibular division of trigeminal nerve, but not the posterior wall. And in this MCQ clearly it was mentioned, when the examination of external auditory meatus was done, the otoscope or the examining device was introduced to the posterior wall. And my dear friends, posterior wall of the external auditory meatus is getting innervation from vagus nerve, not trigeminal nerve. So this is not the correct answer. Facial nerve. So why facial nerve is not the correct answer? Actually, when we talk about facial nerve, if we talk about facial nerve innervation in terms of ear, it is basically giving innervation to its, it is giving one of its branch, that is called as the Coda tympanic nerve, which traverses in the middle ear. Coda tympanic nerve is actually carrying afferent fibers for taste sensation of anterior 2/3 of tongue and parasympathetic preganglionic fibers. It also carries the coda tympanic nerve is also carrying secretomotor fibers, that is parasympathetic innervation for two glands. One is SMG and SL, that is submandibular gland and sublingual gland. These kind of presentation was not mentioned in the patient, and also a small motor component of this a branch, that is nerve to stapedius. Nerve to stapedius is involving giving is supplying stapedius muscle, but it is not carrying any kind of cutaneous innervation. So, this is the reason that facial nerve is not the correct answer. Okay. Now, coming to the other option, that is accessory nerve. So, why accessory nerve or 11th cranial nerve is not the correct answer? 11th cranial nerve or accessory nerve is not the correct answer because it provides motor innervation to two muscles, sternocleidomastoid muscle and trapezius muscle, and if these two muscles are involved, the movement of the neck and the shrugging action of the shoulder, so or the overhead abduction. So, nothing of this action. So, not a single point of injury representing the trapezius or sternocleidomastoid muscle was mentioned in the MCQ. Loss of overhead abduction was not mentioned, any kind of neck movement involved was not mentioned, any kind of shrugging movement being involved or loss was not mentioned. So, this can't be the correct answer. Also, accessory nerve is not involved for the innervation of external auditory meatus. So, is it okay everyone? Let us move on to the 5th MCQ. Okay. So, we have done with the 4 MCQs, let us move on to the 5th MCQ. So, today we have got 10 clinical MCQs, we will solve all of it. So, I will read the MCQ for you and you have to mark the right answer. A 51-year-old woman comes to the physician complaining that the right side of her face is feeling funny for the past 12 hours. Her past medical history is significant for type 2 diabetes mellitus. Physical examination reveals asymmetry of her face when she smiles, when she puffs her cheeks, when she closes her eyes tightly, and there is also effacement of right nasolabial fold and her mouth is drawn towards the left side. Okay. So, this is the complaint which is seen in the patient, okay, because once so you have to give, so I will just all these presentation which was mentioned, that is the face is feeling funny, puffing of the cheeks is not possible, closing of her eyes tightly is done, asymmetry of the face, loss of nasolabial fold on the right side, and the face is drawn towards the left hand side. So, what is this condition called as? You have to know and you have to tell me which is the right one. Option A is attenuated sense of touch onto the right side of the face, decreased tearing from the right eye, failure to elevate the palate by saying the word ah, inability to sweat onto the right side of the face, loss of taste sensation from posterior 1/3 of the tongue. So, you have to tell me the correct answer. So, Prakhar Sharma has given the answers 5th B. What about others? What about others? What about others? Sam is telling B. Sam is telling B. Prakhar Sharma is telling B. Okay, let me see what is the correct answer. Okay, Sam is again, so we have got Prakhar and Sam has given the answer. Let me explain it. So, actually the correct answer is B, which is given by Sam and Prakhar, very good. Decreased tearing from the right eye. So, anybody can guess this clinical symptoms which is mentioned here, so many clinical aspect is mentioned. So, this is pointing us to which condition? This is pointing us to which condition? Which clinical condition the MCQ is presentation of the patient is there? Any idea? Any idea? Actually, the patient is suffering from Bell's palsy. Okay, the patient is suffering from Bell's palsy. Actually, the onset which is mentioned here is presented with the facial paralysis and all. So you can see here the patient with Bell's palsy is typically having loss of nasolabial fold, as you can see. Location, yes, bulbar palsy, absolutely right, Sam. Inability to close the eye. Why? Because facial muscle orbicularis oculi is lost its innervation, asymmetry of muscle, loss of nasolabial fold. So all these signs and symptoms which was mentioned when the patient was pointing to a facial nerve injury, that is the injury extracranially, and these will lead to Bell's palsy. Asymmetry of the face, these are all presenting the features of Bell's palsy. Depression, disappearance of the nasolabial fold and mouth is drawn. So when one side of the face, ipsilateral side of the face is paralyzed, the face will move to the other side, contralateral side, and this is seen in the condition involved in Bell's palsy. Also we know that coda tympanic nerve is a branch from the facial nerve which is giving taste sensation to anterior two-third of the tongue, so that will also be seen. Decreased tearing, why? Because lacrimation is affected, and we know that greater petrosal nerve is involved, which is again a branch of facial nerve. So because of this, decreased tearing will be there. Hyperacusis means similar sound, normal sound will appear as a greater intensity sound because of the involvement of branch of another branch of facial nerve. What is that nerve? Okay, what is that nerve? If that is involved, then that means normal sound will appear loud because of the involvement of nerve to stapedius, okay. Yes, Sujita, lacrimal, absolutely right Sujita, opposite side, absolutely right. Means face का जो turning होता है वो opposite side का होता है, क्योंकि ipsilateral side के सारे structures involved हो जाते हैं, because after extracranially involvement of facial nerve has been done. So I would like to just give you elaborate feature of the facial nerve important branches, and what these are giving in you and suggesting you what is the clinical patient presented, clinical sign and symptom presented in the patient. Now see here, if greater petrosal nerve is involved, see here, lacrimal gland, greater petrosal nerve is giving, so see here, greater petrosal nerve is supplying which structure? I will use an, okay, see here, greater petrosal nerve is involving, it is giving innervation to lacrimal gland. This will lead to loss of tearing, okay, decrease tearing will be occurring. Coda tympanic nerve is also a branch of facial nerve, and it is supplying anterior two-third of tongue. So taste sensation for anterior two-third of tongue and give secretomotor fibers to submandibular and sublingual gland. Yes, absolutely right Shruti Kumar. And posterior auricular nerve, okay, it can be involved, stylohyoid, then posterior belly of digastric, and also you can see muscles of facial expression. These are getting innervation from the terminal branch of facial nerve. So yes, these sign and symptoms, that is involvement of this can lead to involvement of the posterior auricular branch. It can lead to the paralysis of stylohyoid muscle, the posterior belly of digastric, the muscles of facial expression, and also coda tympanic nerve is being involved. Then the loss of sensation from taste sensation from anterior two-third of tongue, secretomotor fibers or the saliva secretion from submandibular gland and sublingual gland can be involved. Greater petrosal nerve is involved, so loss of weeping or tearing from the eyes will be involved, and the facial muscle paralysis will be there. So the presentation of patient will be loss of nasolabial fold and all. So these are sign and symptoms presented in the patient, and one of its branch, if you remember, nerve to stapedius is there. Nerve to stapedius is also a branch from the facial nerve, and if nerve to stapedius is involved, the patient will hear normal sound as a loudspeaker sound. What is this condition called as? Hyperacusis. Hyperacusis will be there. So see here the other option. So we are now done with the right options, and let's see the other option. One of the option was increase sense of touch on the right side. My dear friends, if we talk about the touch, if we talk about general sensation, yes Sujita, absolutely right, Hyperacusis means the sound which is normally, when I am talking to you, it's normal sound, you can hear. But if your stapedius muscle is not working, what will happen? The damping down effect of the sound to the inner ear will not be possible, and you will feel like my sound is loudspeaker to you. Okay, so that is called as the condition. Now other thing is trigeminal nerve. Okay, yes Sam, when trigeminal nerve is involved, the sensation, please see this diagram. Trigeminal nerve is having three divisions. What is it? Ophthalmic, the maxillary and the mandibular. So this diagram, let me just highlight this diagram. Okay, so when I highlight this diagram, what you can see that this is the territory, this whole is the territory here, which is showing the territory of involvement of ophthalmic division, sensory innervation, territory of ophthalmic nerve. Next to it is the territory of involvement of maxillary nerve. So this is the involvement of maxillary nerve, and rest to it, this territory which you are seeing with green color, this is whole territory of involvement of mandibular nerve. So yes, only the angle of mandible, is not involved here. Why? Because it is getting innervation from great auricular nerve. Okay, sensation, normal. Okay, normal sensation, that is normal sensation, general sensation, my dear Sujata. Normal sensation, that is the normal sensation is the sensation of the facial skin, it is by trigeminal nerve. Muscles of facial expression is by facial nerve, but normal sensation, now the normal general sensation is by the sensory innervation of the facial skin and all is done by trigeminal nerve. So this can't be the correct answer. So this is the reason it can't be the correct answer. Let's move on to the other option. Failure to elevate the palate when saying ah. My dear friends, what is this indication going towards? This indication is for gag reflex. Now gag reflex can be the right answer if there is involvement of either glossopharyngeal nerve, that is 9th cranial nerve, or vagus nerve. So none of this nerve was involved. The nerve which was involved in this patient was 7th cranial nerve. So this can't be the right answer. Got the point? Okay. Inability to sweat on the right side of the face. Actually, sweating is the condition, and the loss of sweating will be seen in condition of Horner syndrome. And if Horner syndrome was the case, there should be have the involvement of sympathetic innervation. So Horner syndrome is generally seen in cases of lower trunk palsy, lower trunk brachial plex palsy. This is the condition where Horner syndrome is seen. Also it is seen in cases of Vasovagal Bursa syndrome, Pica syndrome, posterior inferior cerebellar syndrome. And if Horner syndrome was the condition, sympathetic innervation should has been involved, not the motor part of facial nerve. And the presentation of the patient will be ptosis. What is ptosis? Partial. Basically it is partial ptosis. That means drooping of upper eyelid, that is LPS, paralysis of levator palpebral superioris. Yes Sujita, you are absolutely right. Constriction of pupil, okay, dilator pupil is not working, anhidrosis, loss of sweating, and anophthalmos. What does that mean? Sunken eyeball. So these are the features which is consistent with the sympathetic nerve being involved, innervation is involved. That is generally seen in condition of Klumpke's or lower trunk palsy, or in conditions of posterior inferior cerebellar syndrome, that is Vasovagal syndrome or lateral medullary syndrome. And this is not the correct condition because facial nerve motor supply has been involved. So other option which was mentioned, one more option was there. That option was option number E, loss of taste sensation from posterior 1/3 of the tongue. My dear friends, loss of taste sensation of posterior 1/3 of tongue will be involving which nerve? Glossopharyngeal nerve. And glossopharyngeal nerve was intact in the patient, so this can't be the correct answer. See this diagram. So if you will see this diagram, you can clearly appreciate that all the muscles, so I have included this diagram. In this diagram, whole of the innervation of, this is giving you the detail of the innervation of the tongue. So all the muscles are supplied. When we talk about the muscle, all the muscles are supplied by hypoglossal nerve except the platoglossus, which is supplied by 10th cranial nerve. Also the anterior part of the tongue is having lingual nerve as general sensory supply, Coda tympanic nerve has special taste sensation, and posterior part of the tongue is getting innervation, both general and that of special, from glossopharyngeal nerve. And the posterior most of the part along with this, what is this? This is E for epiglottis. What is this? This is epiglottis. E for epiglottis, this is laryngeal cartilage, and epiglottis and posterior most part of the tongue is getting innervation from internal laryngeal nerve. Again, internal laryngeal nerve is a branch of vagus nerve. So this is the reason all other options are absolutely wrong except facial nerve. So is it okay, everyone? We have done the correct and incorrect option. We have done the correct and incorrect option. Let's move on to the next MCQ, that is MCQ number 6. Okay, question number 6. Yes, let's move on to the next one. Question number 6. Yes, Sujita, absolutely right. Sujata, yes, absolutely right, dear. Now let's move on to question number 6. All of you please mark the correct answer. A 34-year-old male with squamous cell carcinoma undergoes surgical neck dissections. While attempting to ligate the inferior thyroid artery, the surgeon accidentally damages a nerve that is lying in close proximity to it. So which of the following nerve would be the damaged nerve, whether it is superior laryngeal, recurrent laryngeal, ansa cervicalis, hypoglossal nerve, or accessory nerve? 5 options are there. You have to mark the correct answer. Question number 6. Question number 6. So yes, so answers, let others answers and then I will come up with the explanation. Question number 6. Okay, so I am getting answers like Shruti, Glozo, 6B, okay, BB. So Harini, Prakhar, Dipti, Sujata, all are telling B. Shruti Kumar is telling Glozo. Okay, Glozo, which is Glozo? I have not included as an any option. Okay. So yes, if we come up with the explanation, the correct answer is recurrent laryngeal nerve. Recurrent laryngeal nerve is the correct answer. B option is absolutely correct. B option is absolutely correct. Okay, so for the correct answer here, we have to know the blood supply of the thyroid gland, and we have to know what is the relation of nerves in relation to the superior and inferior thyroid artery. So we are knowing that, we can mark the correct answer. So actually the key point which is mentioned in this MCQ is ligation of inferior thyroid artery. So when inferior thyroid artery is ligated, which nerve is injured? Recurrent laryngeal nerve. And when superior thyroid artery is ligated, all of you, when superior thyroid artery is ligated, which nerve is injured? External laryngeal nerve. External laryngeal nerve. So let me explain this. I have included this diagram. It will be useful for you to revise. Okay. Inferior thyroid artery arises. Inferior thyroid artery is a branch of thyrocervical trunk, and we know that thyrocervical trunk is a branch of first part of subclavian artery. It's a branch from first part of subclavian artery. Now, superior thyroid artery is a branch of external carotid artery. Actually, it's the first anterior branch of external carotid artery, and both these arteries, superior and inferior thyroid artery, is providing blood supply to thyroid gland. So you can clearly see in this diagram. What you can, this is the thyroid gland which is shown. The blood supply is given by inferior thyroid artery, thyroidema artery, and that of superior thyroid artery. Okay, superior thyroid artery towards the apex and inferior thyroid artery towards the basal aspect. So here superior thyroid artery is a branch of external carotid artery, inferior thyroid artery is a branch of thyrocervical trunk, which is a branch of first part of subclavian artery. Now the next diagram is beautifully showing you the relation of nerve and artery. Before that, firstly you read the explanation. Okay. From thyrocervical trunk, the inferior thyroid artery courses deep to the vagus nerve, and when it is coursing deep to the vagus nerve, it is going towards thyrocervical trunk से inferior thyroid artery arise करता है and it goes towards the basal aspect of the thyroid gland. Just before meeting thyroid artery, It lies in close relation to which nerve? Recurrent laryngeal nerve. So, this is the reason recurrent laryngeal nerve is the correct answer. So, let me show you this. So, just see this diagram. So, if you see the, here we can clearly see. So, here you can see this is the recurrent laryngeal nerve which is forming a loop around arch of aorta and it is lying in close association with inferior thyroid artery when reaching the basal aspect of the thyroid gland. Here you can see superior laryngeal nerve is giving one of its branch that is called as external laryngeal nerve. External laryngeal nerve is a branch of superior laryngeal nerve and it is running in close association with superior thyroid artery. So, that means superior thyroid artery is running close with external laryngeal nerve and inferior thyroid artery is running in close association with recurrent laryngeal nerve. So, see here. So, recurrent laryngeal nerve branch of a vagus loops around the aortic arch on left hand side and subclavian artery on the right hand side and it is supplying, it is giving innervation to all the muscles of the larynx except cricothyroid. Cricothyroid muscle is getting innervation from external laryngeal nerve. So, when there is unilateral injury to the recurrent laryngeal nerve, the patient will have hoarseness of voice, will have difficulty, respiratory difficulty and airway obstruction. So, same thing it is shown here also, as you can see here. Recurrent laryngeal nerve running, you can see here this two structure, the recurrent laryngeal nerve close to inferior thyroid artery and here you can see here the superior thyroid artery is lying close to the external laryngeal nerve. So, here in the previous diagram we can see this is the superior thyroid artery running close with the external laryngeal nerve. So, this is quite clearly seen in this MCQ, clearly seen in this definition. So, see here one more diagram. Superior laryngeal nerve is giving a branch that is external laryngeal nerve which can get injured if external laryngeal nerve can get injured when we go for ligation of superior thyroid artery. So, yes, this is a better diagram you can appreciate here. This is superior thyroid artery lying close to the external branch of superior laryngeal nerve. This is external branch. Can you see here this this is the artery and here this is the nerve. The nerve is external laryngeal nerve and the artery is superior thyroid artery. So, this is the explanation of injury of the nerves being involved. Now, let us see the incorrect option. So, we are clearly done with the correct option. Let us move on to the incorrect option. Ansa cervicalis was mentioned as one of the option. It can't be the correct answer. Recurrent branch of recurrent laryngeal nerve is a branch of vagus nerve, dear. Recurrent laryngeal nerve is a branch of vagus nerve and vagus nerve is giving another branch that is superior laryngeal nerve. Superior laryngeal nerve again divides to give internal and external laryngeal nerve. Okay, Sujita, superior laryngeal nerve is giving external and internal laryngeal nerve. Recurrent laryngeal nerve is a direct branch from vagus. Now, ansa cervicalis is actually a nerve loop. Okay, this nerve loop is formed by C2 and C3 as an inferior root and C1 nerve is running along with hypoglossal nerve forming superior root. Okay, the location of this ansa cervicalis loop is lying on the anterior sheath or anterior wall of carotid sheath. Where is the location of this loop lying? Ansa cervicalis is a nerve loop which is formed by two roots, one is superior and another is inferior. The inferior root is formed by C2 and C3 and the superior root is formed by C1 running along with hypoglossal nerve and ansa cervicalis is located in the anterior wall or sheath of carotid sheath which is containing internal jugular vein, carotid artery, vagus nerve. Now, this loop of ansa cervicalis is mainly supplying infrahyoid muscle, that is inferior belly of omohyoid, sternohyoid, sternothyroid and superior belly of omohyoid. Only one of the muscle, so this has also been asked in previous year, which infrahyoid muscle is not getting innervation from the nerve loop? The answer is thyrohyoid. Thyrohyoid is getting directly innervation from the C1 carrying the fibers of hypoglossal nerve. So, this can't be the answer because infrahyoid muscle was not paralyzed or not involved in this MCQ. Moving on to the next, another option was hypoglossal nerve. Actually, hypoglossal nerve can't be the correct answer because if hypoglossal nerve is involved, there will be paralysis of the tongue muscle. See here, In this diagram you can see this is the hypoglossal nerve, which is going towards the neck, which is going towards the tongue region and giving innervation to genioglossus muscle, styloglossus muscle, actually all the muscles of the tongue, genioglossus, styloglossus, we have got chondroglossus, okay, all these muscles is getting innervation from the hypoglossal nerve, except that of palatoglossus, which is getting innervation from vagus nerve, okay, pharyngeal nerve plexus, but not there is not any single point which was mentioned in this MCQ which was showing paralysis of tongue muscle. So this can't be the correct answer. So this is the reason it can't be the correct answer. Yes, Sujata, palatoglossus muscle is getting innervation from vagus nerve. Rest all muscle of the tongue, that is hyoglossal, chondroglossal, genioglossus, styloglossus, these are all getting innervation from 12th cranial nerve or hypoglossal nerve. Now, one of the option was accessory nerve, and we already know accessory nerve is the nerve which is traversing through jugular foramen and it is supplying two muscles. One is the sternocleidomastoid muscle and the other is trapezius muscle. Sternocleidomastoid and that of trapezius muscle, and if these muscles are involved, the patient will have difficulty in shrugging of the shoulder, neck movement will be involved, but none of these was mentioned in this MCQ, and overhead abduction will be involved. So this can't be the correct answer. Let's move on to the next MCQ, that is MCQ number. Let's move on to the next MCQ, that is MCQ number 7. Okay, everyone? Yeah. So firstly I will read this for you and then you have to mark the correct answer. A 53-year-old man present to his physician's office with a dull aching pain in the right shoulder. Okay, he states that his pain is worsening with the movement and that it often interferes with his sleep. The patient cannot recall any kind of traumatic event prior to the starting of the pain, but does report that he experienced increased discomfort after helping his daughter to move into her college room 1 week ago. Okay, his past medical history include dyslipidemia and hypertension, for which he takes the appropriate medication. Physical examination reveals local tenderness just below the acromial process. Okay, so these are the key points. The physician asks the patient to abduct his arm to 90 degree and flex the arm to 30 degrees with thumb pointing towards the floor. C then applies a downward force to the arm. The maneuver elicits pain in the patient's right shoulder and reveals a right-sided weakness as compared to that of left side. A tendon of which of the following muscle is most likely to be inflamed in this patient? What is the correct answer? Whether biceps brachii is involved, deltoid muscle is involved, levator scapulae muscle is involved, serratus anterior muscle is involved, or supraspinatus muscle is involved. A list of clinical presentation of the patient has been given in this MCQ and you have to mark the correct answer. Question number 7, Sam is telling B, what about others? What about others? Please mark the correct answer. Question number 7. Okay, Sam is telling B. Okay, only Sam has given the answer. Okay, Sujata is also telling B. So both Sujata and Sam is telling B. What about others? Sujata and Sam is telling B, so I am waiting for others, otherwise I will explain the answer. So B deltoid, Sujata B deltoid, Prakhar Sharma is telling E, okay, Prakhar Sharma is telling E. Okay, anyone else wants to answer? Otherwise I will come up with the explanation. Don't worry, I will come up with the explanation. Anyone wants to answer? The correct answer is, Dipti is also telling E, Dipti. The correct answer is question number 7, E. E is the correct answer. So both Dipti and Prakhar are correct. Supraspinatus is the answer. The key points which is mentioned in this MCQ was that that local tenderness is below the acromial process, and below the acromial process which structure lies? Okay, below the acromial, the landmark is given. If you will see here, local tenderness is just below the acromial process, and the maneuver which is done by the physician was patient को abduct करते हैं arm का 90 degree, then flex to 30 degree, thumb towards the, and this force, and then she applies downward force. So this maneuver is also showing weakness of that side of the defective side of the shoulder as compared to the left hand side. Actually, most key points which is very catchy in this MCQ is the location of tenderness is below acromial process, and the tendon which is involved in this condition is supraspinatus, and this is the condition of supraspinatus tendinitis. This is the condition of supraspinatus tendinitis. So let's move with this. So rotator cuff, yes Prakhar, subacromial bursitis के कारण, actually so many reasons are there that supraspinatus is involved. Sometimes supraspinatus tendon becomes calcific, sometimes tearing occurs, sometimes subacromial bursitis will compress it. So of the rotator cuff structure, tendon of, if we talk about the rotator cuff muscle that is sits, that is supraspinatus, infraspinatus, we know that subscapularis, teres minor, of all these, impingement of the tendon of supraspinatus. Yes, absolutely right, the correct word. Yes, it get impinged, it get compressed below the subacromial bursa and below the acromial process. So you can see here, subacromial bursa is located below the acromial process as shown in the diagram, and just below it, can everybody see? This is the, let me just, sits muscle. Yes, absolutely right dear. So if you will see this diagram, here you can see this is the subacromial bursa. So if subacromial bursa is enlarged, okay, this is showing the critical zone of the tendon. So if there is a subacromial inflammation or bursa, so what will happen? Below this, which structure lies? Below this, the structure which is lying here, I am highlighting with blue color, this structure is supraspinatus. So supraspinatus tendon can get impinged below the subacromial bursa or acromial process, and it can lead to supraspinatus tendinitis. Okay. So now, due to superior location, supraspinatus tendon is vulnerable to repeated injury or trauma, and at times it gets compressed, impinged between the head of humerus and acromioclavicular joint. So motion that is affected, we know that supraspinatus muscle is causing initiation of shoulder joint. Everyone knows what is the action of supraspinatus muscle. Supraspinatus muscle is causing initiation of abduction. So motion typically involved. So the action which is typically involved inflammation of this tendon is abduction, flexion of arm, basically initiation of abduction. 0 to 15 degree of abduction is done by supraspinatus muscle. Okay. So in the patient, the maneuver which was done by the help of the doctor or the examining physician. Okay. So, but initiation by itself the patient finds is very difficult to do, and it will lead to very painful condition, and see here. So that is the reason the supraspinatus is the correct answer, because loss of abduction and the maneuver was done by the patient which was causing pain in the supraspinatus muscle, and initiation of abduction is painful, and the location was below acromial process. That means it get compressed below due to the bursa of subacromial bursitis, inflammation of subacromial bursa. Now moving to the next. Now what was the other option which was mentioned which can't be the correct answer? One of the option was biceps brachii. Now biceps brachii tendon, we know that biceps brachii origin is as in the form of short head and long head. So the tendon are long head and short head which is passing through glenohumeral joint, and it is inserted into the scapula. Short head inserts into the coracoid process, short head of tendon exerts onto the anterior lip and short. Actually when you will see, this short head is originating from coracoid process, this is the long head which is originating from, we can see the scapula, okay, from the scapula, and both of these are going towards the radial tuberosity. So the location is not exactly below the acromial process, so this can't be involved. Now, deltoid muscle, one of the choice was deltoid muscle. Now, my dear friends, deltoid muscle originates from the clavicle, it originates from acromial process and the scapula. So, exactly it is having a wide range of origin and is inserting into the humerus bone. So, such a large area of acromial process of this deltoid muscle, which is originating from acromial process, clavicular and the spinous process, can't be submerged below the acromial processes. So, this can't be the right answer. So, if you are knowing the origin and insertion of the muscle, it becomes very easy for you to mark the right answer. So, this deltoid muscle is not the right answer. Another option was levator scapulae muscle. So, levator scapulae muscle can't be the right, it's absolutely wrong. Why? No confusion can be there with the levator scapulae muscle, because the origin is from the transverse process of first, second, third, fourth cervical vertebra, and it is inserting onto the superior angle of the scapula medial aspect, as you can see. So, levator scapulae muscle is not lying in relation to acromial process. So, this can't be the correct answer. Okay. Now, the other option was serratus anterior. Again, serratus anterior can't be the correct answer because it is having a wide origin in the form of 8 or 9 digitations, which is in the form of, so these digitations, when you will see, these digitations appear like this, as you can see here, and so it is called as serrated, and from here it originates and insert onto the medial border of scapula. So, again this is not getting impinged or compressed below the acromial process. So, this can't be the correct answer. And when serratus anterior muscle is involved, generally the patient presentation is winging of scapula, which was not mentioned in this MCQ. So, this can't be the correct answer. So, is it okay everyone? Can we move on to next MCQ? MCQ number 8 everyone, question number 8. So, yes, we have got this 8 and 2 more MCQs are there. So, we will complete this. A 19-year-old female presents to your office complaining of right hand clumsiness. Physical examination reveals decreased sensation over the fifth finger and flattened hypothenar eminences. So, the affected nerve injured in this case will be the presentation of the patient is decreased sensation on fifth finger and flattened hypothenar eminences. So, which is the correct answer? Whether the involvement is of carpal tunnel, whether the involvement is of hook of Hammett, whether the involvement is of surgical neck of humerus, head of radius, coracobrachialis muscle. So, which is the correct answer? Question number 8. Question number 8. Sujata is telling B, hook of Hammett. What about others? Sam is telling 8th B. Okay. Okay, so let me explain it. Prakhar is telling B. Okay. And Harini is telling B. So, most of you are telling B. Okay. Yes, so the B answer is right, and the key points which is mentioned in this MCQ is right hand clumsiness, loss of sensation over the fifth finger. So, medial aspect of the finger or the this fifth finger is getting innervation from, the little finger is getting innervation from ulnar nerve, and also hypothenar muscle is involved. So, these 2 points are giving us the key points to mark the correct answer, that is ulnar nerve. So, we get the hint that the ulnar nerve is involved, and ulnar nerve will be involved in the area below the hook of Hammett. So, B is the correct answer. Okay. Yes, Dipti. Yeah. So, I have highlighted the key points which was mentioned. The key points, ulnar nerve provide, what were the key point? The key point which is mentioned is ulnar nerve provides sensory innervation to the fifth digit and medial half of the fourth digit, also the palmar and dorsal aspect of the hand. So, both palmar and dorsal aspect of the hand on medial aspect is getting innervation from ulnar nerve. So, yes, ulnar nerve is involved, that is clearly marked in the MCQ. In the hand, ulnar nerve innervates all. Actually, most of the muscles of hand, intrinsic muscles of the hand is getting innervation from ulnar nerve, that is palmar dorsal interossei, muscles of hypothenar eminences, palmaris brevis, and also adductor pollicis and third and fourth lumbrical muscle. So, in short, I have written all the muscles of hand which is getting innervation from ulnar nerve. Now, my dear friends, let's locate the reason of ulnar nerve being compressed. In the wrist, ulnar nerve passes between the hook of Hammett. It is passing between the hook of Hammett and the pisiform bone in a canal. The name of that osseofibrous canal is, the name of that fibro-osseous canal is Guyon's canal. So, this is the reason where commonly ulnar nerve get compressed, and if ulnar nerve is compressed in Guyon's canal, what will it lead to? It will lead to dysesthesia, or means decreased sensation of ulnar sides of the hand and weakness of intrinsic muscles of the hand, which was mentioned as in the MCQ the key points, and clearly we get the location of ulnar nerve injury. Carpal tunnel syndrome. Why carpal tunnel syndrome is not the answer? So, we already know the carpal tunnel is the area which is lying below fibrous retinaculum, and the nerve which is passing below it is the median nerve. So, median nerve is injured. Yes, absolutely right, Sujata. Median nerve is injured in the area of Guyon's canal. Compression occurs there. Patient typically experience with impairment of the movements like knitting, swing, picking, pin, paresthesia and attack, and numbness occurs in the radial 3½ of the digits of the affected hand. So, carpal tunnel can't be the answer because median nerve is not compressed in this patient. Surgical neck of humerus, again it can't be the answer. Now you must be knowing why, because axillary nerve is involved if surgical neck is involved, and it will lead to paralysis of, yes, it will lead to paralysis of teres minor and deltoid muscle, and also sensation will be lost from the upper lateral aspect of the arm, that is lateral. Upper lateral cutaneous nerve of arm is a branch of axillary nerve, and axillary nerve is not compressed, and if deltoid muscle is involved, loss of abduction, and also in chronic condition there will be loss of shoulder contour, which was not mentioned in this MCQ. Head of radius, other option was head of radius. So, okay, head of radius, the deep branch of radial head is commonly involved in condition of radial head subluxation, and when head of radius involved or subluxation of radius head occur, the condition is called as nursemaid knee, and it is a common injury which is seen in case of children's when there is a wrong practice of swinging the children's by their hands, and in that case there can be nursemaid knee or head subluxation, and head subluxation can damage which branch of radial nerve? Absolutely right, posterior intrusious nerve or the deep branch of radial nerve, and it will lead to, if deep branch of radial nerve is involved, the posterior intrusious nerve of radial branch is involved, it will lead to paralysis of extensor compartment muscle, and the result will be wrist drop. What will be the result? The result will be wrist drop, which was not mentioned in this MCQ. So, this can't be the correct answer. Okay, one more option was there, that was coracobrachialis. Now, my dear friends, you know coracobrachialis is innervated by which nerve? Musculocutaneous nerve. Okay, coracobrachialis is innervated by musculocutaneous nerve, and musculocutaneous nerve was not injured in this patient. Musculocutaneous nerve is not injured in this patient, so this can't be the correct answer. Coracobrachialis is actually the muscle of anterior aspect of flexor group of muscle, and it is actually lies deep to, coracobrachialis muscle lies deep to biceps brachii, and it is innervated by musculocutaneous nerve. Musculocutaneous nerve is generally injured by stab wound or nothing of the loss of, none of the presentation of the patient like loss of the function of coracobrachialis, biceps brachii was mentioned in this condition. So, this can't be the correct answer. Very easy. So, I think most of you have marked it right, and we have ruled out the incorrect option and also seen why the correct answer was ulnar nerve. After location of ulnar nerve, the injury is in the Guyon's canal lying below hook of Hammett. So, can we move on to next MCQ, that is MCQ number 9. So, this is a mixture of clinical and image based MCQ. So, just go through this MCQ, I will just explain it, and at the end of the session 2 more MCQs, 9th and 10th. I would also like to tell you about my free sessions on the Unacademy platform, timing, so that you can attend my free sessions. So, firstly let us solve the question number 9th. A 56-year-old man came to the emergency department because of persistent left wrist pain. While walking his dog 5 hours ago, fell forward to the ground and landed on his outstretched left hand. Examination shows mild swelling over the dorsum of the left hand with preserved range of movement. There is also point of tenderness. Tenderness is there on the anatomical snuff box. X-ray is also given of the wrist as shown below. The patient is at a risk of developing which of the following conditions or complications: avascular necrosis, Dupuytren contracture, osteomyelitis, compartment syndrome, carpal tunnel syndrome. So your time starts now. Mark the correct answer. So yes, Akshit Bhatt, Prakhar Sharma, Dipti. So I am getting A as the correct answer. Let me see others answer and then I will explain this answer. Akshit Bhatt, okay. So I got A as the correct answer from Dipti, Prakhar and Akshit Bhatt. Waiting for others, otherwise I will explain. Abhishek is telling D, Dupuytren contracture, okay. What about others? Now the correct answer here is, if we go through the correct, and the correct answer is avascular necrosis, which is given by many of the students and aspirants. Yes, the correct answer is A. The clinical history which is provided in the patient with giving the key point which is mentioned here is tenderness over anatomical snuff box. So we know that anatomical snuff box is if there is a tenderness in anatomical snuff box, there is involvement of scaphoid bone, and fracture of scaphoid bone leads to avascular necrosis because of its peculiar blood supply, which I will explain. Okay, peculiar blood supply. So okay, and also the radiological image which has been shown to you is showing the fracture of scaphoid bone. So let me show you the enlarged view of this diagram. Okay, so here you have to see the bones. So very nicely you can see here in this diagram, this is the ulnar bone, this is the radius bone, this is the lower end of the radius bone, and this is the ulnar bone. So and the carpal bones can be seen here. So see here, this is the first lateral carpal bone and you can clearly see this is fractured at this point. So which bone is this? This is scaphoid. Which bone is this? This is scaphoid bone. No doubt about this. No doubt about this. Next, C looks too pretty, try to catch her. So from lateral, we know that radius bone is lying lateral, ulnar bone is lying radius bone is lying lateral, ulnar bone is lying medial. So the next to the scaphoid, C is scaphoid. C looks too pretty, try to catch her. This is the mnemonic which is used. So looks for which bone? Lunate. Looks too pretty. So which bone is this? Okay, so this is looks too pretty. P, this is pisiform. Okay, sorry, this is P for pisiform and this is triquetral. This is P, this is triquetral. C looks too pretty, try to catch her. Try to catch her. Okay, try to catch her. So here two bones slightly overlapping, that is the trapezium and trapezoid, okay, TT, and this is capitate. This is C, the largest carpal bone, and this is hamate. This is H for hamate. Okay, so yes, we got all the bones here and we can clearly see the fracture is involving the scaphoid bone. Okay, the fracture is involving the scaphoid bone. C looks too pretty, try to catch her. Trapezium, trapezoid. So this is trapezium, trapezoid, capitate and hamate. Trapezium, trapezoid, this is zoid and this is capitate and this is hook of hamate. So now why avascular necrosis? So now coming with this, why the answer is avascular necrosis? The reason of avascular necrosis being the correct answer is why? Because the fracture of the fracture of scaphoid carpal bone is related with avascular necrosis due to its peculiar blood supply. So let me explain that also. Dorsal scaphoid branch of radial artery. If we talk about dorsal scaphoid branch of radial artery, majority of the scaphoid bone get blood supply from this branch. This blood supply, this is the major source of blood supply to scaphoid bone. And my dear friends, please note down this point. This is reaching from which pole? Distal pole, not the proximal. Distal aspect se reach kar raha hai blood supply. So that means it is having retrograde manner of blood supply, and this retrograde manner of blood supply get interrupted. It get interrupted if the fracture of scaphoid bone involves, which is generally giving a clinical symptoms of pain and tenderness in the anatomical snuff box. Scaphoid fracture, because its peculiar blood supply which is entering the scaphoid bone towards the dorsal or distal aspect, when it is involved, it will affect the blood supply and nutrition of the scaphoid bone, and ultimately the condition will, if a prompt treatment is not done, ultimate condition is avascular necrosis or non-union case. In long lasting cases, it can also result in arthritic conditions. Okay. Now my dear friends, let me show you this diagram. This diagram is showing you the peculiar blood supply. This diagram is showing you the peculiar blood supply of scaphoid bone. So see here in this diagram, clearly you can see this is the scaphoid bone and this is fractured. So scaphoid bone is fractured, necrosis is occurring into the proximal pole. Why? Because the dorsal scaphoid branch of radial artery all is reaching. Can you see? It is turning, it is reaching the proximal aspect P from the distal pole, from the distal aspect of the scaphoid bone, and this peculiar blood supply is injuring the blood supply. It is making the scaphoid bone deprived of blood and nutrition, and ultimately union is delayed, and the union of bone is delayed. That means it is leading to avascular necrosis. Is it okay? Are you understanding, everyone? Okay. Now let's move. So we have got the correct answer. After that, I just want to give you the elaborate brief of the incorrect option, why it is incorrect. So yes, see here, carpal tunnel syndrome. One of the option was carpal tunnel syndrome, and carpal tunnel syndrome again can't be the correct answer. Carpal tunnel is the space which is lying below flexor retinaculum. The structure which is passing and which is at a risk of being compressed in carpal tunnel is median nerve. So when median nerve is compressed, and it is seen in cases of obese people, physiologically seen in case of pregnancy, and fatty people, also seen in conditions of hypothyroidism, diabetic cases and rheumatoid arthritis, and the patient will complain of tingling sensation, pain, paresthesia, and so this can't be the correct answer. Now moving to question number, the other option, one of the option was compartment syndrome. What was the option? Compartment syndrome. My dear friends, compartment syndrome again can't be the answer. What do you mean by the word compartment syndrome? Compartment syndrome का मतलब होता है, it means that a pressure is built up in a compartment where pressure is built up and it is an enclosed space. Compartment syndrome ka presentation generally is seen in the patient, which is usually occurring after bleeding and swelling of the injury. Okay, and this is basically related with the long bone fracture of the leg or the forearm. So it is generally seen in the fracture of tibia, fibula or radius or ulnar bone, long bone fracture, not that's the carpal bone. So compartment syndrome can't be the correct answer, because none of this presentation was present in the patient. The patient was having, the key point which was mentioning was the tenderness in the anatomical snuff box. That means fracture of scaphoid bone. So this is not the correct answer. Dupuytren's contracture. Okay, so few students has also given this as the answer. This can't be the correct answer. The reason is that actually it's a chronic condition. Dupuytren's syndrome is generally a chronic condition, and there is palmar fascia is getting contracted. So we know that whole of the hand and palm is having a fascia covering it, that is palmar fascia, which is supporting and giving protection to underlying nerves and vessels. So in condition like those people who has got a a fixed amount of working hours, and like cobblers, shoemakers and all, they have got they are just using their palmar, they are creasing their palmar aponeurosis so much and using it. So it is actually a chronic condition which is a progressive fibrous change or fibroproliferative disease of palmar fascia. It's a scarring disease which progresses on the palmar aspect, and ultimately it causes the flexion, contracture of the fingers. Okay, so this is generally seen in the condition and seen in the shoemakers or cobblers. So this can't be, because the history of the patient was acute and it was not a chronic condition, so it can't be the correct answer. Okay. So osteomyelitis, one of the condition was osteomyelitis. Again I want to describe why osteomyelitis can't be the correct answer. The reason why it can't be the correct answer is it results from, the result of osteomyelitis is an infective condition which is seen due to the infection or emboli being spreading. The seeding or the spreading of the infection occurs via hematogenous spread, and generally bacteria are involved, on organism are involved, and this is seen by in cases of bacterial invasion. The most commonly involved bacteria is Staphylococcus aureus. Okay, a prompt treatment should be done along with a antibiotic coverage, and this can be seen only in the open injury, and it's an however unexposed bone. That means if a bone is not having an open injury or a severe injury, then it is unlikely that it is seen there in that condition. So osteomyelitis again can't be the correct answer. So is it okay everyone? Everyone, we have discussed not only the correct answer but also the incorrect option. So can we move on to the next MCQ? So we have got the last MCQ for today's session. I will explain it, and my dear friends, please wait. I will also give you the information of my upcoming session, because that will be useful for you, and how you can attend my free session. So I have planned 1 or 2 sessions tomorrow and day after tomorrow. So I want to give you the information about that. But let's firstly finish the last MCQ of clinical MCQs, and again it is a collaboration of both clinical and that of the image based MCQ. So let's move on to the this 10th number MCQ. Okay everyone, so it's again showing a radiological imaging of the articulated hand. Question number 10. A 34-year-old female presents to the emergency room, emergency department, after falling in the bathroom. She had got stuck in the bathroom and fall down. She complains of wrist pain. And numbness in her right palm. Based on her symptoms, you suspect that she has dislocated the lunate bone. My dear friend, exactly the bone being involved is mentioned in this MCQ. Which bone, dear? Lunate carpal bone. So please identify the lunate bone in the X-ray. All of you, please identify the lunate bone. Identify the lunate bone, dear. Lunate, we have to identify lunate. So I got Prakhar is telling it's C. Prakhar is telling it's C. What about others? Akshit Bhatt is telling C. Harini is telling C. Okay, all of you are telling same answer. Okay. So yes, Satyajit has arrived, and Satyajit is telling D. Harini is telling D. Sam is telling D. Okay. Yes. Anyone else wants to answer? Then I will come up with the explanation. So D or C, D or C. Okay. So yes, D or C. So what is the correct answer, dear? Can I come up with the explanation? So I will show you a very good radiological image in which I will give you the key points of identification of the bones. Dipti is telling D. My dear friends, C is not the correct answer. The correct answer is D. The correct answer is D. D is the correct answer. Why? So confusion ही नहीं है. D सही answer होगा. कैसे मैं बताती हूँ. Let me highlight this diagram. So see here. Now the hint is in the previous MCQ also. This is which bone? This is the R for radius bone, and this is, so let me use red color, see. This is R for radius and this is ulna. So two bones are articulating with the radius bone. Can you see? Mainly two bones articulate. So C kaun sa bone hai? Good afternoon Satyajit, good afternoon dear. C is scaphoid my dear friends. D is lunate. D is lunate and C is scaphoid. Wrist joint is formed by articulation of distal aspect of the radius bone with that of scaphoid and lunate mainly. So which will lie laterally? C looks too pretty, try to catch her. So C is for scaphoid and D is for lunate. Is it clear to everyone? I will show you a very clear diagram of radiological image, then it will be clear to you. See here. Let's move on to the correct answer. So a fall on outstretched hand. So the presentation of a patient will be a fall on outstretched hand. Dorsiflexion is the classical presentation of the patient with having lunate injury, and lunate is one of the proximal carpal bone. So we have got two rows of carpal bone. One is the proximal and other is the distal. C looks too pretty. Scaphoid, lunate, tricuetral, pisiform. These are proximal row of carpal bone, and try to catch her. Trapezium, trapezoid, capitate and hamate. These are distal row. So here when you will see the articulation of radius bone, it is articulating with two bones, especially scaphoid and lunate. And if the presentation of patient is like fall on outstretched hand as was presented, the patient has fallen in her bathroom, and after that the bone which was highlighted and the bone which we have to guess was involved was the lunate. Okay, because the key point lunate was already mentioned in this MCQ, तो हमें lunate को locate करना था. Let me show you this diagram. So all of you, please concentrate here. See here. Clearly radius में तो कोई problem नहीं है. Radius और ulna का distal end, no problem. Okay, radius. So see here, two bones directly articulate with the radius to form wrist joint. Wrist joint is basically called as radiocarpal joint. Wrist joint को हम क्या कहते हैं? Radiocarpal joint कहते हैं. It is called as radiocarpal joint. Radiocarpal joint. And the articulation of wrist joint is with scaphoid and lunate. So lunate will lie medially. So lunate medially hai. So we have got two of the proximal row. Other is the tricuetral, and over the tricuetral, can you see here? Just over the tricuetrum, the bone which is sitting very nicely is the small pisiform. Pisiform is like a pea. क्या बोलते हैं हम हिंदी में? मटर के दाने की तरह लगता है. Pisiform looks like मटर का दाना. Okay. Now we have to see the other row of the bone, that is the distal row of the bone, and clearly we can see the distal row. The first is the trapezium, trapezoid. The largest carpal bone is the capitate, and the next is the hamate. So everyone, can you appreciate this? Ojasi Sarma, good afternoon Ojasi. Okay, so everyone, can you appreciate the carpal bones in this diagram? So the bone which we have to guess in the MCQ was lunate bone. Okay, so yes, so lunate bone is the correct answer, no doubt about this. Now what is A? A is trapezium. Yes, so actually A is the trapezium. Actually A trapezium hai because it is the lateral most bone of the distal carpal row. So see here, when you see the trapezium bone, clearly you can see trapezium bone is the lateral most bone of the distal row. It is the lateral most bone of which row? Distal row. So this is A. This is A. Okay. Next. The choice B is capitate. Yes, very nicely you can see the largest carpal bone. This is the largest carpal bone, and this is the B choice. This is the capitate. This is the capitate. So same thing we can see in that image also, but this is very clear image so that you can correlate with the diagram. So B is capitate. C is scaphoid, my dear friends. Yes, I already told you in that image that C is the lateral most bone. See here, C is the lateral most bone of the proximal row. Of which row? Proximal row. So C is scaphoid. C is scaphoid. And E is tricuetrum. E is tricuetrum. E is located in the proximal medial wrist, and it is lying towards the medial aspect, and over triquetrum the bone which is sitting is pisiform. So, see here, this is the triquetrum bone, and over the triquetrum the bone which is sitting is pisiform. So, done, we have done with the explanation of this. So, let me just go through this and I will once more show you this diagram. This was the MCQ. Let me just rub this, and once more after the explanation I will highlight this diagram, the same diagram which was presented in the MCQ, to make you understand the location. So, again coming to this MCQ, ulna bone, radius bone, C is scaphoid, C is scaphoid, D is lunate, D is lunate, okay, E is triquetrum, triquetrum, okay. A is the lateral most bone of the distal row, trapezium, it is trapezium, and B is capitate, B is capitate, okay, got it? In this there will be one more bone and there will be one more bone here and there will be one over here, okay. So, यहाँ पे ये trapezium है, ये trapezoid होगा, trapezoid, T for trapezoid, and here this will be H for hook of hamlet, and this small I will just make it with a blue color, I will just small bone sitting over this, this will be the P for pisiform. So, done the identification of all carpal bones in this MCQ, very good. So, before ending the session, what I want that you should know about my upcoming sessions, okay. So, my dear friends, those who want to be the part, of my free sessions on the Unacademy platform, they can they can use this code ANAT10. So, firstly they have to download the app of Unacademy, they have to find their goal as NEET PG, and then they have to search for Dr. Monalisa Anatomy free sessions. Actually, link of session is provided in my Telegram group. My Telegram group is Monalisa Anatomy. So, you can be the part of my free sessions by using the unlock code ANAT10. And what is my free sessions coming up? So, my free sessions are like this. 6 p.m. session I am taking, that is especially useful for those students. 6 p.m. session I am taking, that is especially the conceptual anatomy sessions. The upcoming sessions are, today is 18th June, I am taking lungs part 1. Tomorrow I will cover up the whole lungs along with the bronchopulmonary segment and applied aspect. And my dear friends, on 20th June is Sunday. 20th June is Sunday, so your colleges is academic load आपको कम होगा. So I am taking the afternoon session, that is 12:30 p.m. So 20th June only 12:30. Rest every time my 6 p.m. session is conceptual anatomy session, and this will be extremely useful for the students targeting for next examination or the first year MBBS students. So, you can be the part of my conceptual anatomy session, absolutely free. This is the Telegram group of mine, Monalisa Anatomy. So, you can join the Telegram group of mine, Monalisa Anatomy, and you can get the link of all my upcoming sessions. Also, I want to tell that free clinical special sessions are there. So, previous year free special class sessions are there, previous year MCQs I am discussing. So, tomorrow is 19th June. So, you can be the part. This is extremely important for those who are targeting next examination, those who are targeting NEET PG 2021. So, they can also, those who are targeting INICT, they can be the part of this session. Unlock code for the first time user is ANAT10, and this is the Telegram group of mine where the link of session will be provided. So, link of session will be also provided in Let's Crack NEET PG group, okay. Also, my plus subscription is going on. So, plus subscription ke liye you have to take the subscription of Unacademy, and also many subscription, many of the sessions are going on the Unacademy platform, we have already seen. So, anyone who wants to take the plus subscription of Unacademy, they can use my code ANAT10. So, you can use my code ANAT10 for 10% discount, and you can be the part of plus subscription where you can be the part of your targeted course, and prof exam course is also there, first year, second year, third year. So, and you can target your entrance exam, whether it is next NEET PG or INICT or FMGE. You can use the code NAT10 for 10% discount, and you can also be the part of my must know topics of NEET PG 2021. The schedule of my must know topics of NEET PG 2021 starting from 19 and ending on 21st June. So, I have started the sessions from 10 AM tomorrow, and it will end on 21st June, that is up 12 PM it will end. 5 sessions are there. Total of 10 hours is targeted for the quick revision of important topics of NEET PG 2021. Also, I will discuss MCQs related to the topic. So, these are upcoming sessions, and those who want to be the part of these sessions and those who want to follow me, and you can start following me on the Unacademy app, so that you can get the link of all my upcoming sessions, and also you can take the plus subscription if you want to target your preparation in a targeted direction. So, all the best, keep studying. Thank you so much. So, any doubt, or can I end the session? Please let me know. So, I have also included in the initial part of the session, I have included the list of all upcoming sessions and the ongoing sessions on the Unacademy platform, and also the discount which is going on. So, anyone who is interested, any doubt, please let me know, and again I will come up with this session. All the best, keep studying. Thank you so much. Yes, Dipti, thank you so much. So, I will again take one more session on the clinical anatomy MCQs, and will share you the link in both Let's Crack NEET PG INICT group and also in my own group. Okay everyone, thank you so much. Thank you. All the best.